credit, please reach out to myself, Kathy, and we will help you, and Nicole, and help you get that completed. So good afternoon, and thank you for joining us today. It is my pleasure to introduce Dr. Michael Conway. He is the chairman, Department of Surgery at St. Francis Hospital since November of 2013. Dr. Conway attended University of Delaware for his undergraduate, then pursued his love of medicine at Jefferson Medical College in 1989. He completed his postgraduate surgical residency at the Medical Center of Delaware, which is now known as Christiana Hospital. He was chief resident from 1993 to 1994. In 1996, Dr. Conway co-funded and is now president of the surgical group of Delaware Surgical Group. His practice has 3 surgery centers, and they operate at St. Francis, Christiana, and Wilmington hospitals. The practices specialize in laparoscopic procedures, hernias, and gallbladder procedures. Under Dr. Conway's leadership at St. Francis, we became the first center of excellence in the hernia surgery in all of the state of Delaware, which was a really big deal to the state. He is very active in Delaware and Pennsylvania healthcare communities. Dr. Conway is a clinical professor at Jefferson College of Medicine, an advanced trauma life support instructor, and serves on numerous hospital-based committees. On a personal note, he has been married for 29 years with 2 children. His son is studying law, and his daughter just graduated with an MBA. Dr. Conway is an avid Flyers, Eagles, Sixers, and Phillies fan, and his favorite pastime is restoring furniture. So after he retires in medicine, we can start sending him our furniture to restore. So I like that. Dr. Conway will be presenting on gallbladder diseases today, testing modalities and treatments. So please give Dr. Conway a warm welcome.
All right.
Thank you, Doctor.
Want to say thank you for certainly setting everything up. And I am a general surgeon, and I like to say that because over the years our title hasn't changed. As a matter of fact, people will say, "Oh, you didn't specialize in anything, huh?" So as a general surgeon, and all general surgeons will know this, our specialty is the gallbladder and hernia. It's pretty much our everyday routine. And then acute care surgery has come into play as a name for what we do as general surgeons as well, which is all the things in the abdomen that can go wrong: appendicitis, diverticulitis, bowel obstructions, perforations, all that good stuff. So having said that, I wanted to start with something that, something I'm most familiar with, and with the gallbladder. So going forward, I'm going to be going through the slides. The learning objectives, we like to try and keep things simple. So just diagnosing someone with gallbladder disease, the testing modalities of what we do to diagnose it, and then treatment itself. So as far as the big picture with gallstones, I usually used to say, and still do now, prior to the pandemic, where if you were at a party and you're talking with people randomly and you have a conversation and you said, "Oh, I got to get my gallbladder out," or "So-and-so, my wife's getting her gallbladder out," and then you'll find people come out of the woodwork where, it's such a common thing that, so-and-so had it, they had it, so everybody knows somebody that's pretty much had their gallbladder out. It's said that about 10 to 15% of Americans have gallstones, so it's pretty much good job security for us general surgeons. Female to male ratio, we state 80 to 20, and probably more like 85-15. The guys do get it, but most of the time it's a sporadic event. That just because somebody has gallstones or gallbladder disease doesn't mean they're gonna get it. One interesting thing I do seem to hear is when you ask people about their history, does anybody else have it? Your mother, grandmother, sister, any guys in the family? And when they say their father had it, it's always interesting because it's not uncommon to be followed with, and her sister had it, and her father's sister had it, and her brother also had it. So when a guy has it, it seems to kind of have a different bit of a run. But for the most part, it's females that mostly are presenting with the gallbladder disease. As far as big picture, when we say gallbladder disease, well, what does the gallbladder do? So the gallbladder itself is just an organ that stores and concentrates bile. That's all it does. And as you see on the screen, it's pretty much not bigger than what you're seeing there. Sometimes it's a little bigger, a little smaller, depending on what phase it's in. And when it's distended or full with bile and before it contracts. But the liver is the thing that makes the bile. So as far as the liver goes, it does a million things, but one of the main things it does is makes bile that as an exocrine secretion, it gets secreted down into the biliary tree. We call it that because it looks like a tree. You got a long trunk with limbs that are going up into the liver substance itself here. And then the gallbladder has this common connection through a two-way street called the cystic duct. And it communicates with the common bile duct. So they're the main structures that we focus on and come into play when it comes to the gallbladder itself. So again, function-wise, it makes bile. Bile is a substance we use in our GI tract to help break up fatty foods we eat. So that when we eat a meal, basically your foodstuffs will come down through your stomach or your esophagus into your stomach, and as it starts to, the whole process of digestion starts to begin, and you have the bile going, or the food going into the small intestine.
Hi, this is Gina. I don't know if Dr. Conway is speaking, but if you are, we can't hear you. You'll need to unmute yourself. Thank you.
I think, am I back on?
Yes, we can hear
Hello?
you now, Dr. Conway.
Yes, we can hear
I'm
you.
sorry, how far did I get? I'm not sure where that went. I was talking about the gallbladder and the bile and its function as a concentrating organ for the bile.
Yeah,
Yes,
remember
I think that's where you
went
left
through.
off. Thank you.
Okay. So, all right. So, sorry. Yeah, I'm not sure what happened there, but I heard reverb and then they started telling me I was muted.
Okay.
So, as far as the GI, the gallbladder is concerned, all it does is concentrate and store bile. It doesn't make it. Bile is made in the liver, and the liver does a million things, but it makes the bile that goes down in what we call the biliary tree, which shown here, we call it the biliary tree because it's a long trunk with the limbs that go up into the substance of the liver to collect the bile. And it's just a mechanical process. The exocrine function of the liver will have the bile go down this long trunk to go directly into the intestine, but when we're not eating, it gets siphoned up into the gallbladder through this two-way street called the cystic duct. And this cystic and common duct are our main structures for us to focus on. When we eat a meal, it goes into the stomach, starts to go around the first part of the intestine. There's a signal from the small intestine called CCK or cholecystokinin, same stuff that you hear about when you have a HIDA scan, which we'll talk about later, and that stimulates the gallbladder. But it naturally stimulates the gallbladder to contract, send out the concentrated stuff that's been holding to go into the common duct, to go down here into the first part of the second part of the duodenum so that it can help with the process of breaking up the fatty foods that we eat. So basically all it does is break it down from big globules to little globules, and then you see that the common bile duct here meets with the pancreatic duct, and the pancreatic enzymes get secreted all at the same time as well from the CCK as well as from something called secretin that comes from the cells of the intestine that tells you digestion is going on. So as foodstuffs go into the next 18 feet of small intestine, the jejunum, terminal ileum, everything gets absorbed. All the stuff that's not absorbed dumps itself into the cecum or right colon at the end of the terminal ileum, and then the colon's job is basically to absorb water, package up everything so that you can deliver it at your own time. As far as the bile itself, when we talk about gallstones, well, you know, why do they form? And that's also another question that's asked at events where people say, why do I get gallstones? So gallstones are basically cholesterol-based. They can be of other types as well. People with hematologic disorders or a leaky heart valve or something like that that breaks up red blood cells can lead to other types of stones. But the most common are going to be the cholesterol-based. And it has to do with the way your cholesterol is in relationship to what's called bile salts and lecithin, fatty acid, the ratio. So that if the cholesterol component becomes higher or the other two components become lower, then you can become what's called lithogenic or become a gallstone former. So if you look at the majority of people that get gallstones, we say females more than males because the hormone, the estrogen, can affect that ratio and create a higher level of the cholesterol in the secretions of the liver into the biliary tree. Another interesting scenario is through that same idea is rapid weight loss. And this is talking people, you know, who lose a good bit of weight in a short period of time. The cholesterol, as it leaches out from the fat cells and they shrink, can go into the bloodstream that then gets filtered in the liver, and the liver then puts it into the bile, and that sets off that ratio on the cholesterol level. On an interesting note, when we first started practice, first couple of years, and gallbladders are us, so that's what we're doing all the time. Had a young girl, 22, she lost like 80 to 100 pounds in a short, like a 6-month period, and everything went great. She developed gallstones, we took out her gallbladders, laparoscopic, she did well. But her mother, when I talked to her afterwards, said, oh, how could this happen? And I started explaining that whole ratio thing, thinking I'm educating her and that sort of thing, and I'm feeling good about it. And then she wanted me to put that in writing so that she could sue the Slim Fast company because she developed gallstones. And I tried to be thanking the Slim Fast company because that helped her to lose her weight. It's just these things kind of got realized as weight loss and bariatric surgery actually had come into play. Another interesting scenario, just from a physiologic standpoint, is Crohn's disease or any other disease that may affect what's called the terminal ileum, or the last part of the small intestine as it joins the colon, where there's no absorption that goes on there. So people with Crohn's disease have the last part of their ileum that may not absorb, and there's an enterohepatic circulation of the bile salts. So the bile salts get absorbed there and go back into your liver area so it can be put into the bile and then keep it from being lithogenic. With Crohn's, it dumps right into the colon, or with people with distal small bowel resections or bowel obstructions and had to have a resection of the terminal ileum, they won't absorb that. So they're at higher risk to develop gallstones as well, again, because it affects that ratio. So it's more of an interesting physiologic discussion. As far as the main clinical scenarios of gallbladder disease, the most common reason we're seeing people is ongoing, intermittent, I'm going to say biliary colic, where you will have a physical stone, just like when you have the intestinal colic, you have a physical change that's causing a backup of flow. In gallbladder disease, you can see over here in this picture on the right bottom, showing a little stone that gets kind of stuck in the cystic duct. So the stones have basically been there for years, but they're just rolling around in the gallbladder, and then every once in a while, for whatever reason, something will get stuck in the cystic duct, just bad luck, and then cause some symptoms. And again, most of the time it's this acute, like a biliary colic that comes on, lasts a few hours, goes away, and then you hope it doesn't happen again, but then when it does, that's when you may seek treatment. People with acute calculus cholecystitis, these are ones that we may see in the emergency room or an urgent call from a primary care doc because they had an attack and they get pain and it won't go away. And that's when it's associated with, we say, cholecystitis, because there may become an inflammatory change associated with it. So fluid around the gallbladder. There's always bacteria in the gallbladder, and as long as there's good flow out of the gallbladder through that two-way street of the cystic duct, they don't get an infection. But when you block that up and it stays blocked, that can lead to fever and reaction and that sort of thing. One of the more concerning outcomes of gallstones, and this, we say, presents maybe 5% of the time at the hospital. That's a number that's thrown around, that people's initial presentation may be gallstone pancreatitis. And you can see just from the anatomy, and it's the smaller gallstones that can cause these problems, not the big ones. People are impressed with big gallstones when we take pictures of them and give them to them, but it's the small ones that can do the most harm, in a sense. So the little guys can get out through this cystic duct and then get down into this common bile duct or distal duct, and you can see the relationship to the pancreatic duct where it empties into the second part of the small bowel, and then you can see the distal common bile duct coming down. So if a stone gets lodged right here, it's going to back up everything. A lot of times it's just inflammation because the stone will pass because there's a pressure that's inherent in the common bile duct, and it'll push this through. Once it does, you have the residual effect of the pancreatitis, though, that can be pretty significant, and usually that gets the people's attention. They're admitted, and we let things settle down. But a lot of times they don't have acute cholecystitis. They actually just have it down in the more distal area, and their gallbladder disease isn't bad when it comes to an operation. Jaundice, meaning everything's backed up. That's when you might have a stone in the distal duct like is shown here, and then closer up here where it's not affecting the pancreatic duct, but it's in the mid to distal common bile duct, and it just backs up all the bile into the gallbladder, into the liver, and people present with jaundice. A lot of times that's associated with a painful jaundice because they feel that inflammation in the retroperitoneum as well, as opposed to painless jaundice, which people hear about with pancreatic cancers. So as far as a typical presentation, we hear about the 5 Fs, which are always the fertile, 40, female, fair, fat. We're going to say overweight, but that way it was a good way to remember things, and they seem to be the people that were more apt to develop gallbladder disease. And again, all comes back to that concentration of the cholesterol to the bile salts and lecithin. Okay. Their presentation can be anything from, as I'm going to use the word, foregut pain. Foregut meaning anything that's from basically the middle of your chest down to your navel area. So symptoms of the foregut are coming from what's the blood supply from the celiac plexus, celiac axis, which are the blood vessels that go to the stomach and spleen and liver and gallbladder, pancreas, esophagus, all these other anatomic structures. But your pain can be from any of these areas. So it's not always right upper quadrant. After I ate a pizza, it can be through to the back. It could feel like a belt tightening around their mid-abdomen area, associated bloating, distension, sometimes diarrhea. We're going to show that in the anatomy picture next. Tolerances, nausea, can plus or minus vomiting, doesn't always happen. It's interesting because people a lot of times blame their first attack on food poisoning, and then 3 months later they have another piece of pizza or something good, and they get the attack again and realize, it can't be food poison twice in 3 months. So that's when they may seek attention. Pancreatitis, jaundice as a presentation, like we talked about, it's rare for those scenarios, but usually that's in the emergency room setting. Small bowel obstruction, just for completeness sake, there's something called a gallstone ileus, which is usually in little old ladies that get a big gallstone over years that has eroded through the gallbladder wall actually and into the small intestine, and then makes its way into the distal small bowel, travels about 18-20 feet, and then can't get through the terminal ileal area and causes a mechanical bowel obstruction that we end up operating on. So it's more, again, of an interesting finding, but again, another instance of where the gallbladder can cause a. So as far as the big picture, like we always like to say as surgeons, it all starts with anatomy and ends with anatomy. This is showing the picture on the left with everything expanded and opened up and color-coded, and I always tell patients, it's nice to show this chart, but it's not like that inside. We got a lot of things we got to push out of the way and get out of the way. And if you look at the picture on the right, that's more of the norm in a sense that the gallbladder is not even seen. It's sitting underneath the liver in we say the right upper quadrant area, but it's an organ that actually goes from the lateral aspect to the medial aspect. It's three-dimensional, so it goes from the front or anterior to your posterior, towards your back. It can affect all these foregut areas and everything around it. So when it's enveloped by the liver, the stomach, the transverse colon, the small intestines in there, that's why people get those symptoms of bloating, distension, diarrhea. It can be over to the splenic area, the belt-like tightening when the diaphragm's irritated, given that feeling. So any of those symptoms can be present with people with gallbladder or biliary tract disease. So when you have that, what do? So anybody with those symptoms, this is also where it gets interesting, and I'm giving you the surgeon's perspective, is we'll see patients that haven't had an ultrasound yet, but they got these, they seem to fit the criteria and they have all the symptoms, and they should always get an ultrasound. That's the quickest, easiest, I would say least expensive test you can get, and it's also very sensitive to the biliary tree. Interestingly, I put a picture up here just to show the gallbladder and the gallstone. That's obvious in that picture, but most of the time this ends up looking like a weather map, we say, from a surgical standpoint. We count on the radiologist giving us the reading, because it will not only show the gallstones, but it'll show if there's wall thickening, it'll show if there's fluid around the gallbladder, it'll show if there's dilation of the bile ducts. It's a very good test. And I said should be done, because a lot of times people will go into the emergency room and find out that they had an attack. It lasts hours, but by the time they're seen, they're feeling better, and the ER just says, well, you're not dying. They do all kinds of tests. They send you home. But it would have been nice if they got the ultrasound, but they didn't, and then it's done as an outpatient. So that'd be your first test. CAT scan is a good test, great test for surgeons. We love it for anatomy, and we can read those. CAT scan is not as sensitive, but it's a pretty darn good. It will show if there's things going on with associated abnormalities, I'll say. So if you have acute cholecystitis, it's going to show the inflammation of the gallbladder. It will show fluid. If you have pancreatitis on your labs, gallstone pancreatitis, it'll show to what degree you may have the pancreatitis. So it's good for that aspect. Other causes of foregut pain. So when we say things like, your esophagus and your stomach, I mean, there's reflux disease, real bad ulcerations of the distal esophagus, duodenal ulcers, duodenal perforation, contained perforation. It'll show if there's things going on from that aspect. So it's a good test. But most of the time we still like, even where a CAT scan's done, to follow it up with an ultrasound at some point, because we want to know what the bile ducts look like to make sure they're okay. MRI, not a first-line test, but it is very sensitive. It'll show for if there is suspicious ductal dilatation for a common bile duct, if it's bigger than a centimeter. Some people say 1.2 centimeters, then it should be further evaluated for some sludge or something that may be in the common bile duct. And that's where an MRI comes in. I've also used MRI. We've had this where people have been sent to us for gallstones and or biliary tree type problems, and they don't see a gallbladder actually on the ultrasound, which is interesting. Or they'll see stones but no gallbladder wall. And as surgeons and been doing this for 25 years or so, there's times where people have gone in for an operation and can't find a gallbladder. So an MRI is a good test for that anatomy, and feeling better about when you go in and it's there and you can't figure out why the ultrasound didn't show that. HIDA, CCK, HIDA scan is basically a study of nuclear medicine where they inject you through the IV, and then everywhere that bile would go, the HIDA material goes. We say CCK is a functional test. It's the same stuff that comes from the duodenum naturally, cholecystokinin. That's what we use to measure biliary dyskinesia and to what degree they may have dysfunction. We say anything under 35% is considered abnormal for an ejection fraction. And the interesting part of that, though, is also 15% of the population walking around with no symptoms also has an ejection fraction below 35%. So in the right clinical scenario, you get the appropriate testing, and it should set you on the path of whether they need something done for the gallbladder. The ultrasound, though, is your standard for your first test, and usually that's all that's needed. So as far as big picture, what do we do now? So you got somebody who fits the criteria, they got all the right signs and symptoms. What do we do for them? First off, people will always want to say, you know, what can I do about this? Well, you always tell people, well, if it looks good, don't eat it, because the biggest stimulus to the gallbladder is fatty, greasy type foods. So you want to minimize those. From a surgical standpoint, there are no really good other answers except surgery. Now I put that in there because a lot of times us surgeons get commented upon for not thinking too much, and we just kind of try and go in and fix things. So duct tape won't work for the gallbladder as well as a lot of other things, but it does have a lot of functions, that's for sure. Surgery, surgery, surgery. I put it up there 3 times because it's important. Patients who we see in the office will consistently, now with Dr. Google and everything else that you can go online and look up things, everybody will come in with a story or something they looked up, and they'll want to talk about it, which I think is great, because I think it's good for education that people look at the internet and have some questions that they can answer, and then we can expound on that when we're in the office. The most interesting thing is this internet cure, I'll call it. It's like a purge diet, and it's the olive oil, castor oil. I put the word murder oil because they might as well throw that in there too. Lemon juice, avocado, ginger, there's you name it, people have tried it, but it's usually followed by the worst attack you can have from your gallbladder standpoint. So people end up with a acute episode that ends up landing them into the emergency room. It usually becomes then associated with your nausea, vomiting, because it really jammed the stone into the cystic duct. There is a medical treatment, and I mention it because people will read about this. Actigol or Ursodeol, kind of a bile acid. It comes back to changing that cholesterol to the bile salt lecithin ratio again, so that you are less what we'll call lithogenic. The problem with it, it takes a long time for it to really have an effect. I don't believe it necessarily melts the stones that are in there, but it will prevent further stones from developing. It's more now with bariatric surgery being very popular for the past many years, and there's been a swing of the way things have gone, where when you have bariatric surgery, there was noted to be a lot of people that were developing gallstones and then having to have their gallbladder out. So then the discussion came on, do you take their gallbladder out at the same time as their bariatric surgery? That was in favor, and now that's fallen out of favor, and I think with the different techniques now, loss is more gradual, so it's not happening at such a rapid pace. But if people are losing it quickly, they may put them on this. The problem when patients ask about it is it also has side effects: diarrhea, nausea, bloating, distension, which could be your gallbladder symptoms and not the symptoms of the side effects of the Actigol. So surgery, surgery, surgery. That's still the path you're going to end up, unless there's certainly a reason that you can't have surgery. So I'll just refer to that as special circumstances. Main reason would be you come into the emergency room with, you think you're having bad gallbladder, and you are, but it also leads, you have a history of heart disease, and you find out you're also having a heart attack at the same time. So we don't want to operate on you in the midst of an ongoing, evolving heart attack. You're sick for numerous days with fever, unexplained, and then all of a sudden you get the right upper quadrant pain, the nausea, vomiting, you come into the hospital, you're sick for days, you get fever and jaundice. People with gallstone pancreatitis, but it doesn't resolve, the pancreatitis isn't going away. There's circumstances we don't want to operate on you right away. You want the inflammation to go down so we can maximize doing everything minimally invasive or laparoscopic as the gold standard. There's something called VIR drainage. That means the interventional radiologist will get involved, and this is a great tool. It's stopped a lot of people from having an open gallbladder right away. We use it in these scenarios I mentioned above because it'll right away make them feel better because it drains the gallbladder. It's a mechanical problem with a gallstone stuck in their cystic duct, and it can't relieve the pressure. So they can relieve the pressure, they feel better, you get over the events above which are listed here, And then 6 to 8 weeks down the road, we do your gallbladder. And I'd say 95% of the time it gets done laparoscopic. I wrote here the word typical male gallbladder. If there were any surgeons on this call, or if I was at a conference of 1 million surgeons and I said, I just did a case last night and it was a typical male gallbladder, everyone in that room would know what that means. The gallbladder in a male, for whatever reason, seems to be a different animal sometimes. The majority of the women who get the gallbladder issues, when we do their surgeries, you can pretty much probably say 99% of the time you're not going to have to convert to an open procedure. I'd say with the typical male gallbladder that comes in through the emergency room, it may be, well, 75% of the time we're going to get away with doing that laparoscopic for you, but there's a higher incidence of the open for the male gallbladder. As far as the big picture, I'm going to go with now the surgical, what we do for surgery, what we're thinking about, and why it can be tricky. Again, this is a nice picture for diagram's sake because it shows obvious where the cystic duct is and the common bile duct, and everything looks pretty straightforward. It's color-coded, it's nice and green, and actually the classic gallbladder, I love to ask medical students, what's the classic color of a normal gallbladder? And they all say green, but the answer is robin's egg blue, which I didn't realize what that meant until I saw a robin's egg, and I went, hey, that looks like a normal gallbladder. So as far as the big picture, when everything's normal, fine, you get this ductal anatomy that we need to be aware of, because our goal is to just separate the gallbladder from the common bile duct. So that when we do that, we're taking away any of the gallstones that are sitting inside the gallbladder, and you're removing it from the biliary tree, and that way flow can still go from the liver down into the intestine and do what it normally does, helping to break up the fatty foods and help with digestion. So you don't need to necessarily modify the diet. Now, I'm going to go to this picture. This is a typical laparoscopic picture, the patient that we had done and took a picture of. You can see when we first go in, it's in the navel area. We're looking up into the upper abdomen here on this picture on the left side. There's the liver, spans from this falciform ligament kind of in the middle. It's the lobes of the liver here, left side, right side. See the stomach right here. The pancreas would be deep to all here. We don't see the pancreas. This is called the omentum, this fatty tissue layer. Transverse colons underneath that omentum, right around where the gallbladder is. What's called the hepatic flexure of the colon. So you don't even see the gallbladder. So we grab it and we pick it up, and then this is what you'd see, and it's got that bluish color. If you got a color monitor there, you can see that it's got a bluish color with vessels, and that's kind of the typical not bad gallbladder, but this is somebody with biliary colic. So intermittently, there's the gallbladder itself. This is called the body of the gallbladder. The fundus is up top, which is what we grab, and then this is the infundibular area where the cystic duct leaves the gallbladder itself. And then the common bile duct is down here, I'm going to say somewhere. Well, the technique that makes all us general surgeons feel good about being general surgeons is our technique to try to not injure any of those other structures and just stay right where that cystic duct is located and take it away. Now, that's all good and well when we got a gallbladder and an anatomy that looks like that, but then there's times we get this anatomy, and you'll see the liver. Here's the gallbladder peeking out. It's peeking out a little more because it's distended, it's tense, it's edematous, it's got fluid around it. This is the omentum here, the colon's underneath here, with an acute cholecystitis. Sometimes even have to drain the gallbladder with a needle before we can even grab it with our instruments because it's so tense. And this is props to St. Francis Hospital, and I'm saying this because it's kind of a cool technology. I think we're the only ones in Delaware and I don't know, surrounding area that we have it for our laparoscopic equipment because we had just revamped our laparoscopic equipment over the past 2 years. But it's a Firefly technology. It does exist for robotic surgery, but not a lot of gallbladders being done robotic, and it's not as pretty as it is for what we can do laparoscopically. This picture here is showing what the Firefly technology is, and it's an injection of material just like a HIDA scan, the nuclear medicine. It's not nuclear medicine, but it's similar in the sense that everywhere bile goes, this stuff goes, and it has no effect on your kidneys or liver or any bad effects, so anyone can get it. The fun part is it can help at anatomy, which we're, as surgeons, wanting to always see so we can minimize any harm. So you see the green there of the liver. This is a real picture, too, of somebody we've used it on. So we take this, I'm showing you this right upper quadrant picture to highlight this area. You can see the gallbladder is not nice robin's egg blue, but it's this pale, thickened color, a little inflammatory. But here's the normal liver. The liver looks like liver with the brownish color. And this is basically the same picture almost, but a little honed into the where the bile ducts are. But you can see the green. The liver lights up green, but the more interesting part is you see the common bile duct lighting up green here and the cystic duct lighting up green here. And if there's a gallstone sitting here, which are, this is the picture of the gallbladder opened up. So she had a distended gallbladder, thick-walled, multiple stones. These are kind of average-sized stones. So smaller are BB size and P size. These are probably, I like to say, marble size, sometimes shooter marble size. But they certainly can be as big as the whole gallbladder and encase it. But this is kind of a typical scenario. But all you need is one blocking up the works here. The gallbladder can't empty into the common duct like it normally would. So what we're doing is using this technology, which we don't have to use all the time. We also take pride in we know our anatomy. But it can't hurt to have a little help once in a while. So you see the common bile duct here, we see the cystic duct here, and artery that leads to the gallbladder is here, and then our goal is putting clips across these area here where the connection is, the common connection, and separating the gallbladder away from the common bile duct and feeling safe about it. Then we just dissect the gallbladder off the liver bed and take it out through one of those little ports. So from a surgical standpoint, that's a prop for St. Francis because it's kind of a neat technology and does have a benefit for patient safety. So surgically, what do we expect? As far as ideal situation, people who have issues with their gallbladder and they have gallstones, you can expect a 98, 100% resolution, I would hope, for most people of their symptoms. Now that implies that the gallbladder was causing all their symptoms. There's a lot of people that have IBS or people with other GI tract issues or the patients with Crohn's disease and that sort of thing who develop stones. Well, this is going to help take care of the symptoms that are related to the gallbladder. And that may sound inherently like makes sense, but and again, if there's any surgeons on the line, I would assume you have patients who start to ask you if it's going to help with their leg swelling, if it's going to make something else go away. What about when I, eat nuts or something like that? Like they're hoping it's going to cure everything. I always tell patients if it makes you jump higher, run faster, your hair grows back, I'm taking full credit for all of it. But we're doing the procedure to take away the gallbladder because that's causing symptoms that can lead to worse conditions if we don't remove it. And there aren't any other real good options for you. I said the word biliary dyskinesia earlier. That's a condition that we see people for where the gallbladder just doesn't work right. It looks fine and it looks normal, but it doesn't have a mechanical problem, but it has a functional problem. So it can act with the same or similar symptoms of this foregut derivatives of feeling discomfort, bloating, distension. And that's where the HIDA CCK scan would come in. I had mentioned earlier, 15% of Americans are walking around with an abnormal ejection fraction, but they don't have any symptoms. So you don't do anything for them. It's just a finding. So with that same thought process, when people have dyskinesia with the right symptoms, we'd expect about the majority, 85%, to be fine. Otherwise, they'd need a further workup for other reasons. Most people and the laparoscopic approach is the gold standard. We only convert to open in this day and age for some of us older folks who are used to doing open, convert there when we have to, and that's all for safety measures to get them over it to take the gallbladder out at the same setting because you're under anesthesia. Most people laparoscopic are back to, I'm going to say, normal activity 3 to 5 days post-op. The biggest ouch is in those first couple of days was from the distension because we use CO2 gas to distend the abdomen and to have a working environment. And that can irritate the diaphragm. We always try to get as much of that out as we can. But by 3 days, that's pretty much absorbed, and people are getting back to normal. What could happen? I'd say the thing that I always make sure I mention to people, because again, this is something that they'll read on the internet, or when they're at that same party and they're hearing about, when they talk about their gallstones and needing their gallbladder out, they'll always have one person or two that comes up and says, oh, when Aunt Millie had it done, she did good with the surgery, but ever since she had her gallbladder out, every time she eats something, she has to go to the bathroom. And it's more of an urgency sort of thing. It's not just diarrhea or loose bowel movement. It's like within a half hour, she needs to find somewhere. And this is just something that can happen. We say 1 in 2,500 people, so we just mention it so we can say it's mentioned. It's something that's controllable. Going to put down there cholestyramine or Questran. And it's interesting because it has to do with the bile salt issue again. The bile salts, when you have your gallbladder out, the common bile duct actually dilates to make up for the loss of we assume, the loss of a gallbladder. So if you got an ultrasound 6 months after somebody's had their gallbladder out, it's not uncommon, they say, that the bile ducts are dilated, but that's just a physiologic response to having your gallbladder removed with the increased flow going through there. Well, sometimes 1 in 2,500, that can be too high of a flow. And the bile salts are an irritant to the GI tract and lead to this diarrhea or loose bowel movement. So it's not what you're eating running through you, it's just the bile salts being irritant. The Questran cholestyramine is a bile salt binder, so it helps with that. The other issue of what could happen, continued symptoms. People with other issues that weren't all gallbladder, and that's when we would talk about further GI evaluation. From a surgical standpoint, bile leaks. That's the thing we want to minimize to happen to anybody, and you hate to have it happen as a result of your technique. So most of the time when there's bile leaks, it's not from that. It's just leaking from the liver bed, which is a thing that can happen with people with bad gallbladders, and you have a completely obstructed cystic duct. There's little communications between the liver and the gallbladder itself that directly communicate, and they can ooze a little bit. That Firefly technology actually can show you if there's some of those bigger ducts that are oozing. The other issue is a clip can fall off. So we use titanium clips. And by the way, for any primary care docs or people on the line, they're not going to show up on like on an MRI, like with an MRI. They can have an MRI because they're titanium, but they'll show up on plain film x-rays. And people ask about that as well. But those clips can fall off, and not because they're bad clips, but because you're doing a lot of times things in the face of a lot of edema or swelling, and you just don't know how the tissues are going to hold it. It's very rare. It should be less than 1% of anything. In the old days, that was a bigger deal than it is now. It's still bad. You don't want bile leaks, and you certainly don't want common bile duct injuries. But I'm going to say the old days, because we didn't have ERCP, they weren't able to do stents, you weren't able to bypass things, let them heal on their own, remove the stent weeks later, a procedure done like an EGD or even as an outpatient. It saves these people from having further surgeries, which, again, I'm going to say in the early 90s and before could be associated with a lot of morbidity and people that would, and mortality, that would die from a bile duct injury. So we do everything to minimize that. I think the laparoscopic process has actually been great because we can see things pretty good. Things are now, you know, high def TVs, and we got this Firefly stuff, so we're kind of minimizing those sort of complications. But it's still going to happen. That's pretty much most of the talk from me. I just want to go through some things that I, in practice, have, you know, we get this as questions from patients. That, you know, now that their gallbladder's out, you know, questions, but before the gallbladder's out, patients will always say, well, can I just continue with a modified diet? Do I have to have my gallbladder out? And the comment's usually, well, we'll see you now or we'll see you later, because the stones don't go away. They're going to continue to be problems. The medical treatment, no, doesn't work. I would say don't do the purge diet, that's for sure. But sometimes people need more convincing, so they take a little more time before they are convinced that they're going to need their gallbladder out, because the symptoms continue. The most common scenario is the frequency starts to get a little closer together and the intensity seems to rise with each episode, and then it lasts a little longer, so they realize they got to they got to do what they got to do. So we end up seeing them. Questions of, can you just remove the stones? Well, no, because your gallbladder will just form the stones again. Plus, if we operate and just make an incision in your gallbladder, that's going to be a nidus for the start of stones to want to form if you already have a lithogenic physiology. Very common question, will I lose weight? And I love that question because the answer is no. You'll probably actually gain weight because now you can eat what you want. You don't have to avoid the pizza and the greasy and the fried stuff because you're on your way to recovery. You should be feeling good. Do I need a special diet? No. We want to tell people that the idea is to go back to your normal diet. The theory is that about the gallbladder that I like to say to people, and I'm pretty sure I read this somewhere and it kind of makes sense to me, but this is a throwback from the good old caveman days when we were meat eaters. So you killed an animal, you picked it up and you ate it, and pretty much it's probably still moving for a lot of that time frame. So you needed a concentrated, thick, nice bile to break up the fatty foods we were eating back in the day. So without eating like that, you should be okay to go back to your normal diet of this day and age. Obviously, a high-fat diet or something that you may go a binge for might set you off with a little bloating or distension or loose bowel movement. And just be aware of that. But for the most part, you should be fine. The cholesterol question, this always comes up because when I say or go over the physiology and I say, it has to do with the way your bile handles the cholesterol or your liver handles it. And it doesn't have anything necessarily to do with high cholesterol of the blood. So they don't need to do anything for that. Can you get gallstones again? The answer is no. You never say never in surgery, but for the most part, no, because the concentrating mechanism of the biliary tree has been taken away. So everything should just continue to flow, flow, flow. People who have stones 6 months, a year later, chances are it just meant a sludge or a stone got pushed into there during the surgery. And it wasn't a primary stone of the biliary tree, but secondary. Will I get colon cancer? This is somewhere written as well, and I think there was some information on this years ago that having gallstones can be related to colon cancer, having your gallbladder out can be related to it, and the answer is no. So we don't want anybody not having their gallbladder out, which can lead to bigger problems because they're worried about a colon cancer diagnosis. So you just tell them to make sure they're doing their screenings and following up for, as you would for any colon cancer screening regimen. Lastly, I would say a GI evaluation, because a lot of times we'll see patients, patients with that have seen a gastroenterology doc, and they've already had the diagnosis of an ultrasound showing gallstones, the criteria, they have all the signs and symptoms, and then they see a GI person, and it took 2 months to see them, and next thing you know, they're getting an EGD, a colonoscopy, and then sent to us to have their gallbladder out. So you don't need a GI evaluation for classic gallbladder issues and signs and symptoms and foregut thinking it like that, like could it be something? Well, it could be, but we like to say common things happen commonly. So I would say the GI evaluation is when you're getting into the biliary dyskinesia scenario, or you have somebody that also sounds like they're having IBS issues and no gallstones, and you want them evaluated, and you have the GI person do their big evaluation before they tell you, yeah, go back and see that guy and have your gallbladder taken out, because it sounds like it's that. So that pretty much wraps up, what I'd like to say. I think we're running out of time. Hopefully my microphone's been on the whole time. I'm going to hit the last slide that just asks if there's any questions, comments, or concerns. Anybody there? Oh, that would be bad.
That was wonderful,
Yeah.
Dr. Conway.
Oh, I was going to say that would be bad if I was talking for the past 40 minutes and
It was very
everybody
good.
said, what?
Very nice.
It's the slide that I needed to put on there for the ability to go get the credit activity. And again, no financial interest in anything.
Mm-hmm.
I just
And
leave
like I
that up.
said, if anybody has any issues trying to get the credit, just contact Kathleen, Nicole, myself, Deb Campbell, and we'll help you get that. Also, I did take attendance and I'm sending it out so that we can follow up with you to make sure that you fill out the form and you get your CE credit.
Right?
There's a question in the chat.
Okay.
Yep. Oh, what's that? You might have to read it to me because I don't know if I know how to chat.
Okay, I've got it. So it's Dr. Wagner, and he said, how does a bile duct leak present?
Present? Yeah, after somebody has their gallbladder out and we think everything's fine, it's usually a slow leak. So and then once it's leaking, bile is irritating to the peritoneum and your abdominal cavity. So that's when people end up back in the emergency room post-op day 2 or 3. And the first thing in any surgeon's mind is, oh, geez, sounds like they got a leak. So they end up going to the emergency room. They'll get blood work. It usually will show their bilirubin's elevated. And they won't necessarily be jaundiced because it hasn't seeped into their tissues yet. But their bilirubin will be up because it's getting absorbed into their system. And ultrasound will most likely be done because it's quick, but a CAT scan is something we like because it'll show if there's a collection that can be drained. The goal is to get the catheter in from interventional radiology, control the discomfort, and then an ERCP from a gastroenterology docs that do that, and then a stent placement, and these things heal themselves over time. It's usually a non-operative issue. So the good news is we don't have to operate on them. The bad news is you got to go through that. But 6 weeks later, their stents taken out through an EGD outpatient procedure, and they're fine. But that's how it usually presents, is the pain and discomfort of bile leaking and irritating the surrounding peritoneum or tissues. It's pretty intense too when people have it. It's very rare they wouldn't bring it to somebody's attention within a day or two. Good?
And he said, thank you.
Oh, yeah. No problem. Thank you. Thanks for listening.
And Dr. Conway, would it be okay if I shared with everybody your email address or contact information if they have any questions?
Sure.
Or would you prefer them to go, how would they contact you, is what I'm asking.
The email is mconway@che-east.org.
Okay.
And that's our email address from back and forth with you guys that I've used.
Yep, and I'll share that with the participants on the phone.
Sure. Great.
Okay, doesn't look like there are any more questions coming through.
All right.
Okay. Well, everybody, thank you for your time. We really appreciate it. And this is something that we're going to be doing on a monthly or every other month. So as we get the schedule together, we will be emailing you. And please feel free to share with your colleagues as well. So have a wonderful Friday and happy Father's Day to all the gentlemen out there.
Thank you.
You're welcome.
Bye-bye.
Thank you.
All right.
Hello?